call.
Begin.
Welcome to Medicine Grand Rounds, and especially to faculty and residents present here in person. We appreciate that. And colleagues out there on Zoom. I have the great pleasure of introducing Dr. Stacy Charat, who is going to talk to us about multimodal management of chronic pain. Dr. Charat is a primary care general internist at the San Diego VA and a professor of clinical medicine at UCSD. She received her medical degree from Harvard Medical School and completed her residency at Brigham and Women's Hospital in the Department of General Medicine Primary Care track. She is board certified in internal medicine and addiction medicine and completed her VA Addiction Scholar program, through which she received an Addiction Scholars Grant to build an interdisciplinary pain clinic embedded in primary care that focuses on patients with chronic pain and comorbid substance use disorder or complex persistent opioid dependence. She completed the UC Davis Train the Trainer Primary Care Pain Management Fellowship. And now she serves as the VA San Diego and the VISN 22-pack pain champion, where she works on local, regional, and national pain management and quality improvement initiatives. She's a clinician educator, serving as the director of UCSD Internal Medicine Residency Primary Care Track and the medical director of the CPX exam at School of Medicine, and a resident clinic preceptor at the VA La Jolla. So it's a great pleasure to welcome Dr. Stacy Charat, and please join us to welcome her.
Thank you very much for that introduction. And I want to particularly thank Dr. Jessel for inviting me to speak at Medicine Grand Rounds. And I am really glad that I didn't agree until this year to do Medicine Grand Rounds, because if I had given this talk a couple of years ago when she first asked me, it would have been a very different type of presentation that I provided. I probably would have talked mostly about buprenorphine for chronic pain, which is something that I specialize in, but it would have just been telling you about one of the tools that we use in chronic pain management rather than talking about the toolbox. And so over the past several years, as I've been working as part of an interdisciplinary pain team, my thinking about chronic pain, my talking about chronic pain, and my management of chronic pain has really fundamentally changed. And so I'm really happy to be here now talking about the broader perspective of managing complex chronic pain. I have no disclosures. And I want to briefly share a story to explain why a primary care doctor is giving internal medicine grand rounds about chronic pain. And my interest in work in chronic pain actually started with an interest in improving access to care for patients with opioid use disorder. And that came from an experience I had with one of my primary care patients many years ago. He was a relatively young veteran. This is not my patient. This is just a picture to keep you interested. But as a relatively young patient who had an above the elbow amputation after an IED explosion in the military service. And he had developed opioid use disorder in the context of taking prescribed opioids for pain after his amputation. When I became a CCP, he was not using any substances. He was in school. He had partial custody of his daughter. But over the subsequent years of caring for him, he was totally lost to my follow-up. It turned out he had resumed using heroin, was unhoused, living on the street, and then was getting readmitted frequently to the VA due to complications of his substance use disorder. And at one point, he was admitted with an abscess, and I had just been to a workshop at a conference about teaching residents how to use buprenorphine naloxone for opioid use disorder. So I came back from the conference. He happened to be admitted. I had the fire lit under me and went up to talk to him, and he was interested in starting buprenorphine naloxone to treat his substance use disorder. So I worked with it was a research addiction fellow at the time, and we decided we were going to try to get him started in the hospital, and it was really hard, it turned out. We had to talk to pharmacy and nursing and the medical team, and it wasn't stocked anywhere. And we gave him ultimately, after many, many hours, we gave him 2 milligrams of buprenorphine naloxone, which you're familiar with. This medication was a woefully inadequate dose for this patient. And over the next 24 hours, he was in the hospital. He got 1 additional dose of 2 milligrams. So the plan was for him to get discharged and see me in follow-up the next day. He left the hospital. Not surprising to anyone, probably, he did not show up for the appointment with me the following day. And I found out a few days later that he had actually died after he left the hospital. And he died in police custody. We actually don't know the details. His records were sealed by the police. But it was this real significant wake-up call for me, recognizing that I had really failed him as a primary care doctor, honestly, years before that. And then we failed him as a health system in our attempts to get him care when we just really couldn't provide the care that he was seeking in an efficient and effective way. So I started working with a group of key stakeholders in different aspects of the hospital to start working on projects to improve access to care for opioid use disorder. And it turned out that there was a subset of patients that really didn't have anywhere to go. And those were patients who had chronic pain, often on high doses of prescribed opioids, but who also had either comorbid substance use disorder or very strong physiologic dependence on opioids, who were really no longer getting benefit from the opioids. We have excellent addiction psychiatry treatment at the VA, but they don't typically manage pain. And then primary care, who's prescribing the opioids, felt like these opioids were really no longer serving their purpose, and those patients had nowhere to go. And so that's when I started working with a phenomenal pain pharmacist, Serena Chang, and we started working with patients who kind of fall into this gray area in between substance use disorder and chronic pain, or who have them as comorbidities. And so that's why I'm here today giving this presentation. And I also hope it's a plug for primary care, because it's amazing and you can learn a ton from your patients. And also just a reminder that we're really so lucky to be physicians, because we get to learn new things throughout our entire career, and your career can change and will change in really unexpected ways throughout your life. And I think that's a really special and unique thing about being a physician. So moving on to why I'm actually here. There's 3 take-home points that I would like to convey during this presentation. The first is that most chronic pain is at least partially nociplastic in nature, and I'm going to define that term in a minute if you're not familiar with it. 2 is that multidisciplinary pain management, and particularly emphasizing pain neuroscience education and non-pharmacologic treatments, are a safe and effective way to treat chronic pain. What I really want to say is it's the best way to treat chronic pain, and that's what I believe. The evidence may not be strong enough for me to make that claim in writing, but I really do genuinely believe that. And then finally, to really make a plea to all of you that internal medicine physicians are in all subspecialties and in primary care really well poised to provide pain neuroscience education to our patients, which will ultimately improve the chronic pain management that we provide. So my first point regarding nociplastic pain, I'll illustrate this with 2 x-rays, and I'm sure many of you are familiar with this phenomenon, where the patient on the left side of the screen is a patient who had a proximal tibial resection as a kid for osteosarcoma, has severe degenerative changes of the knee that resulted from that, but is working full-time, exercises regularly, and does not have any chronic pain. And the x-ray on the right is from a patient who has an entirely normal x-ray, but has severe bilateral knee pain, walks with a cane, is unable to do most physical activity that he wants to do, and is 100% service-connected and disability from the VA. And we all know from our experience, either from ourselves or from our patients, that imaging doesn't align often with the pain experience for patients. And that's because nociception and pain are not the same thing, but it's still often a conundrum and confusing as to why this is the case. In 2020, the International Association for the Study of Pain redefined pain for the first time since 1979. And they defined pain as an unpleasant sensory and emotional experience associated with, or resembling that associated with, actual or potential tissue damage. And the modification is that clause they added in the middle, which is or resembling that associated with actual or potential tissue damage, in recognition of the fact that people often have pain without tissue damage that we can identify. They went on to say that pain is always personal, that we need to believe patients' reports of their pain, and that pain often serves as an adaptive process in the body, but can also cause a great deal of emotional distress and functional disability. In 2015, the IASP gathered a group of international pain experts to classify pain for the ICD-11. And this group defined 7 different chronic pain categories. On the right are 6 chronic secondary pain syndromes. So those are pain syndromes that are identifiable as being caused by something else. So there's cancer-related pain, chronic neuropathic pain. But on the left, you'll see there's a 7th category of pain, which is chronic primary pain. And chronic primary pain is pain that's been going on for at least 3 months and causes significant emotional distress and functional disability, but cannot be directly attributed to any of those secondary causes of pain. So essentially, the pain is the problem. The pain is not being caused by some other problem. And there are many subcategories of chronic primary pain and a great deal of overlap, certainly, between these different classifications. Our history of the understanding of pain has changed over the centuries, but our modern understanding dates back to the 1600s and Descartes, who described tiny hollow tubes running through the body that transmitted information from the periphery, so noxious stimuli from the periphery to the brain. And that actually wasn't terribly far off, right? With imagining nerves. But that sort of idea of this being a direct linear relationship between external stimuli and the brain lasted for a long time. And in 1965, Melzack and Walls, neuroscientists, published in the journal Science their gate control theory of pain, which you may have heard of. And it was really a paradigm shift in the understanding of the way the pain systems work in the body. And what they described was that large diameter peripheral nerves that transmit sensory information that's not painful, like vibration and touch, can actually close the gate, is how they described it, on small fiber painful stimuli coming to the brain. So it can downregulate painful stimuli. The most obvious way to think about this is if you hit your elbow really hard on something and you rub it, you're kind of naturally stimulating those large fibers, which then downregulate the painful fibers. But they also acknowledge that this downregulation can occur from the brain. So cognitions and emotions can also downregulate painful stimuli from reaching the brain. And this was really a dramatic change in the way that we think about managing pain. In 1996, the same neuroscientist, Melzack, proposed an alternative explanatory model of how pain systems work in the body called the pain neural matrix, coined that term. And that was meant to acknowledge the idea that there are lots of types of pain that occur that aren't directly related to incoming nociception or peripheral stimulation of sensory nerves. And so examples are phantom limb syndrome, for example. And so this is more of a conceptual model to think about the way pain information is produced and the pain experience is produced. But it was also another major paradigm shift in our understanding of pain, because essentially what he described is that pain is not something that is transmitted to the brain. It's something that the brain produces in response to a variety of inputs. So I'm going to say that again, because it's really a different way of thinking about pain. So it's saying again that pain is not something that gets transmitted to the brain from the periphery. The brain is always producing pain. Sometimes it's in response to sensory input, but it can be in response to other types of input or no input at all. And one way to help you kind of imagine this is thinking about the way our brain understands our bodies moving in space. And so normally our brain knows we're moving due to input from our visual sensory system, from proprioception, and from the vestibular system. But if you're sitting on a train, on a platform, and the train next to you starts to move, you often feel the sensation that you're moving fully, enough that you may even reach out and hold on to something so that you don't fall. So your brain is experiencing your body in movement just based on visual stimulus, with no proprioceptive and no vestibular input. And so the same kind of concept applies to this neuromatrix of pain, is that the pain experience can be produced even without sensory input. We all intuitively know that ourselves or our patients have many different factors that impact our experience of pain. This table comes from the VA's manual for cognitive behavioral therapy for pain, but I want to highlight two of the psychological factors that are well studied and documented to impact pain experiences. One is catastrophizing. And the term catastrophizing is basically an exaggerated negative orientation. So a Debbie Downer about, in this case, pain. So people who are when they get a flare of their pain, may automatically think, this is never going to end. I'm not going to be able to work again. My pain is never going to go away. Nothing is going to make this pain better. So that's catastrophizing. And many studies have shown that people who have higher rates of catastrophizing also feel higher intensity pain, even in response to lab-controlled painful stimuli. And similarly, patients who catastrophize often are more refractory to typical management for pain. The other psychological factor that I want to highlight, because it will come up later, is this idea of hurt versus harm. So it's been shown that patients will feel more intense pain when they are interpreting that pain as tissue damage. So when you think that there's something physically hurting you and causing damage, you will feel more intense pain. And this has been shown in a variety of studies. One that I'll highlight is subjects had a very cold metal bar applied to their neck, which I don't recommend volunteering for this study, but half of the participants were told that the metal bar was hot, and half were told that it was cold, and it was cold. And they demonstrated that the subjects who were told the metal bar was hot experienced significantly greater degrees of pain in response to that touching their skin. The idea being that when their anticipation and expectation was of tissue damage occurring, that impacted their pain experience and actually made that experience more intense. So, in response to this increasingly nuanced understanding of the way pain systems work in our brain and our body, Lorimer Moseley, who is a neuroscientist and physical therapist by training and an expert on pain, defines or describes pain as being produced by the brain when it perceives danger to the body tissue and that action is required. Again, not damage, but danger to the body tissue. And that really pain is a threat detection system rather than a damage detection system. And this is something that we can then work with when we are managing chronic pain. In light of this, in 2016, the IASP defined an additional type of pain. We are all probably familiar with nociceptive and neuropathic pain and the examples and descriptions that are provided here. But this third category is called nociplastic pain, and there are some places where it's called neuroplastic, but nociplastic is the term used by the IASP. And this is a type of pain that's caused by increased amplification at the level of the central nervous system. Why this occurs is not entirely well known, but there are lots of various theories, including something you may have heard of called central sensitization, which is sort of a mechanism by which nociplastic pain can occur. And that is when there's increased sensitization, and increased transmission of painful stimuli, or decreased inhibition of painful stimuli. But nociplastic pain is characterized often by widespread pain and often accompanied by comorbid symptoms like fatigue, sleep disturbances, memory changes, and mood disturbances. And a classic example would be fibromyalgia, which includes many of those features. There are some theories that posit maybe there's an increase in endogenous opioids that cause almost an endogenous opioid-induced hyperalgesia as one of the mechanisms, although again, it's not entirely well understood. So this definition of nociplastic pain is that it arrives from altered nociception despite no evidence of threatened tissue damage that's causing activation of the peripheral nociceptors and no disease or lesion of the somatosensory system. And they have published criteria to help define or identify nociplastic pain. And so this can be used for diagnostic when you're diagnosing patients. So if you're following along the black bars along the right, basically it's chronic pain over 3 months that is regional in distribution. that it can't be directly attributed to a nociceptive or neuropathic input, that it involves evoked hypersensitivity phenomena. And so what those are is applying heat or cold or touch, things that wouldn't normally stimulate a pain response, but they do, they cause allodynia. And then also potentially pain hypersensitivity in their areas of pain. And if they have at least one of the comorbidities that I mentioned earlier, then that's probably nociplastic pain. I will acknowledge there's a lot of debate as to whether this diagnostic criteria is the best. And if you read the letters and commentaries on various publications, there's a lot of bickering back and forth between experts in the pain literature, but this is one set of criteria that can be used. Other features that are proposed to help identify nociplastic pain are pain that started without an injury or may have started after an injury, but the initial pain resolved and then pain came back later, which again doesn't really align with our understanding of healing tissue and nociception, or pain that may have come on during a stressful period. It often involves multiple body regions, as I mentioned. It may increase or decrease without a consistent trigger or activity. It often resolves in different environments, particularly in lower stress environments, and then again involves allodynia or hyperalgesia. The use of a body map can be helpful to identify nociplastic pain, and in fact, some suggest that this is the best way to identify nociplastic pain. This particular body map is the Widespread Pain Index, which includes some of the comorbid features that I've been mentioning. But this is a useful tool to provide to patients, and it's not meant to necessarily look at the exact number of painful areas, but regions of pain. So if you divide the body into regions, patients with nociplastic pain will often have at least 3 or more regions of pain that they identify. And that's kind of the most important aspect. This is a body map from a patient that we saw in our multimodal complex pain clinic. And you can see that he has various different types of pain, really covering the entire body. And so a great example of a patient who has nociplastic pain, which may or may not be in addition to other types of pain, but this is a helpful way to identify patients who have nociplastic pain. Really, the pain diagram to describe the different types of pain should look like this, because just like patients who have pain in their low back and also have radicular pain can have overlapping nociceptive and neuropathic pain, many patients, and I've argued probably most patients, have nociplastic pain and other types of pain. And in fact, it's been shown that prolonged exposure to neuropathic or nociceptive pain are actually increase your chance of developing nociplastic pain or having nociplastic pain. And any colleagues in rheumatology that are listening will probably be familiar with this because there are higher rates of fibromyalgia diagnosis in patients who have rheumatoid arthritis and osteoarthritis. In fact, it's been estimated that 15 to 30% of patients who have rheumatoid arthritis also meet diagnostic criteria for fibromyalgia. This was a study that looked at 105 consecutive outpatients with rheumatoid arthritis that were seen in an outpatient rheumatology clinic. And they measured the fibromyalgia tender points. And we don't really use those for diagnosis anymore, but they were using those exact tender points on patients with rheumatoid arthritis. And they found that the number of tender points patients had correlated with the pain threshold. And they measured pain threshold with something called the digital algometer, which applies a standardized amount of pressure to the proximal nail bed. Again, it's going to be more full studies, interesting to get through the IRB. But patients who had higher numbers of tender points had lower pain thresholds, so felt pain at a lower degree of pressure. They also found that patients who had longer disease duration, so had rheumatoid arthritis for longer, had larger numbers of tender points, again, showing that correlation between duration of disease and nociplastic pain. Patients with osteoarthritis also have been shown to have lower pain thresholds than healthy controls. And functional MRI studies show that patients with osteoarthritis have augmentation of pain processing in the brain. This was a study of patients having hip or knee arthroplasty down at University of Michigan. And they looked at 453 patients and found that 150 of them also met criteria for fibromyalgia, which that in and of itself is kind of amazing, right? Like a third of the patients essentially met criteria for fibromyalgia were coming in for joint replacement. And the study measured their fibromyalgia symptoms on a standardized scale before and then after they had their joint replaced. And the study found that patients could be divided into two phenotypes after surgery. About 2/3 of patients after surgery had clinically significant improvement, which is 30% improvement in those fibromyalgia type symptoms. So these are symptoms not directly related to their osteoarthritis, but pain outside of the joint area where they have osteoarthritis and were having it replaced, and then those other comorbid symptoms. So 2/3 of patients had fibromyalgia symptoms get better after their joint replacement. But a third of patients had either worsening or no improvement in the fibromyalgia symptoms after the joint replacement. And so, first of all, I think it's amazing that 2/3 of patients got better, but they also suggest that there may be kind of two mechanisms through which this fibromyalgia type symptoms and nociplastic pain occur. Either a top-down approach where the central nervous system is sensitized kind of on its own, or this bottom-up approach where the nociceptive pain is actually driving the development in some way of the nociplastic pain. Regardless, kind of shows us that there's a great deal of overlap between patients who have an identifiable secondary cause of pain and then also develop an additional pain syndrome on top of that. There's also extensive evidence that chronic pain is a polygenic and complex heritable trait. And so there have been large genome-wide association studies that this particular one that has looked at over 180,000 UK Biobank participants, and they found 76 independent SNPs that were associated with multi-site chronic pain. And they also found genetic correlations with rheumatoid arthritis, asthma, major depressive disorder, and BMI. And so I often think about BMI contributing to chronic pain because of the mechanical loading on joints, but in this case, also looking at correlations in genetics that predispose people to elevated BMI and chronic pain, so a different mechanism. There's also evidence that the human microbiome has an impact on chronic pain experience, and it's thought that microbiota produce serotonin and histamine and glutamate that actually interact with the body's pain processing systems. And then it's been well documented that there are differences among the brain function and structure in patients who have chronic pain, including decreased cortical thickness and then also decreased gray matter. And this has been shown in a range of chronic pain conditions, including fibromyalgia, complex regional pain syndrome, chronic low back pain, and IBS. These images come from a meta-analysis of studies that used a wide range of neuroimaging techniques to show anatomical and functional changes in patients with chronic pain compared to their healthy controls. And the primary areas of the brain that they identified as being involved are the anterior cingulate cortex, the left insula, which seems to be the common denominator in most of the studies, the thalamus, and then the sensory motor cortex, many of which kind of make sense. But they also identified areas that are primarily associated with emotion and memory, like the hippocampus and the amygdala, that are also altered in patients with chronic pain. And some experts suggest that chronic pain may be a kind of persistent sensory memory that is contributing to the perpetuation of this pain. So, in summary, our modern understanding of pain really recognizes the complexity of pain processing through that idea of the neuromatrix, where pain is producing the pain experience, and that there are many different factors that can contribute to the activation of the pain neuromatrix. And then that nociplastic pain represents this activation of the pain response, even in the absence of tissue injury, and that it can be caused by or exacerbated by prolonged exposure to other types of pain. And then what we often see is a patient phenotype who develops chronic pain. In response to that, they kind of protect the body by decreasing activity, which is often associated with a lot of negative emotions, So patients avoid activity, may even socially isolate and withdraw, which leads to more distress, more disability, which causes more chronic pain, and on until you can break that cycle. And that's the goal of treatment, really, is to break that cycle of chronic pain by reducing the threatening input that goes into the neuromatrix and produces pain. And you can do that by providing targeted, gradual activation and desensitization of components of the brain neuromatrix without triggering that pain out. So this is a complex problem, and it requires a complex solution, which brings me to my second point, which is that multidisciplinary pain management is really the best treatment for chronic pain. I'll provide a very brief history of multimodal pain management because it surprisingly started not that long ago. So it was only after World War II that physicians started describing patients with really complex chronic pain. And in the 1940s, an anesthesiologist named John Bonica built the first multimodal pain, interdisciplinary pain facility at the Tacoma General Hospital in Washington. And interestingly enough, I was reading about him. He was also a professional wrestler who made money through med school and residency by professional wrestling. So for all you med students out there, you need some extra money. But he kind of recognized that he was taking care of these patients who needed to see many different specialists, and that they were much more effective when they brought them all into one home. At the same time, there was another anesthesiologist at the VA in McKinney, Texas, who built an interdisciplinary pain facility. And so it wasn't until the 1980s that the first kind of major report on these types of clinics was presented at an NIH conference. And then in the 1990s, there were estimated to be many multidisciplinary pain clinics, anywhere from 800 to 1,000. And what those looked like were highly variable. And you'll see terms interdisciplinary pain clinic, multimodal pain clinic, multidisciplinary, integrated pain clinic. But the idea being that's offering multiple modalities from multiple types of providers all in one integrated clinic. But in the early 2000s, the existence of these clinics really plummeted primarily due to loss of insurance coverage. As you can imagine, this is expensive to do, right? You have a lot of different providers providing really high touch intensive care for one patient with outcomes that can be challenging to measure. So lots of things insurance companies don't love. So by 2005, it was estimated there were really only 84 of these multidisciplinary clinics remaining in the United States. Right after this, though, there was a VA directive establishing the stepped care model of pain management, which I'll describe, which is a way of implementing the biopsychosocial model into chronic pain management. And then in 2016, the Comprehensive Addiction and Recovery Act actually required all VA facilities to develop interdisciplinary pain teams. And then now in 2026, all VA medical centers do have integrated pain teams. They may look slightly different in the way that they're laid out, but they now all have them. So this slide credit goes to our integrated pain team at the VA. But so the multimodal pain management has to address the sensory experience of pain, and we do that through procedures and medications, but it also has to address the emotional experience of pain by teaching people to safe movement and reducing their fear. Also addressing physical damage and kind of promoting healthy behaviors, and by decreasing that threat that patients anticipate with regard to their pain. This is the VA's stepped care model of pain that they published in 2009. And I'll be focusing mostly on step 2 and step 3, but really the foundational step I think is the most important step, and that's why it kind of underlies all the other levels. And that is self-management and patient self-care. It's also probably the hardest thing for us to work on with patients because it requires behavior change with regard to nutrition, movement, weight loss, finding a sense of purpose, social connections, all those things that we know are important for patient health. And then step 1 is primary care services. And then step 2 defines specialty care services, which include subspecialists on their own, but then also integrated pain teams that I'll describe. And then step 3 includes kind of advanced anesthesia diagnostics and treatment, which I won't be focusing on. They obviously have an important place, but it's not my area of expertise. Then also interdisciplinary pain rehabilitation programs, which are integrated pain teams that are just much more intense and involved. And this is not meant to be a linear progression from one step to the next, but rather a kind of cyclical process. Patients should always be including the lower level steps as they progress through the steps based on increased comorbidities or refractory to prior treatments. This is a slide from our integrated pain team that shows the health providers that we have as part of the team. And we really focus on seeing patients with complex pain conditions who haven't improved with prior treatment and who are interested in a multimodal approach. We have 3 interdisciplinary teams at the VA, one that focuses on women's health, one that's a general integrated pain team, and then a team we call the complex pain team, which I'm a part of, where we specifically care for that subset of patients I described earlier who have comorbid substance use disorder or on high doses of prescribed opioids. Our team also provides an 8-week program led by a physical therapist and a behavioral health specialist to teach physical movement and cognitive behavioral therapy concepts to patients. And we are rolling out an orientation class, which will just be a 2-hour class, kind of giving the overview of what we provide. The step 3 level of care are these interdisciplinary pain rehabilitation programs. The VA has many of them. We don't have one in San Diego. There is one at the Greater Los Angeles VA. The most well-known program, and some of these pictures are from there, is in Tampa, Florida. And so it's a 19-day inpatient program that takes referrals from all over the country. And patients stay there for 19 days. They actually work with families and patients with chronic pain. And they have dietitians, psychologists, physical therapists, medical providers, massage, chiropractic, everything basically that you can think of to provide this multimodal, which is remarkable. And they have great success. They often also work with patients who have been on prescribed opioids or prescribed muscle relaxants that are no longer indicated, and work with patients on medication adjustment in a really focused way. And I'll show some outcomes from those programs later. There are many different movement-based therapies that we use for patients with chronic pain listed here. Just to highlight kind of establishing a functional baseline for patients is critical. Many patients will say, I can't do any of those things because of my pain. So you really have to work with patients to find what they can do. That may be walk for 3 minutes on a flat surface. And that's good to still determine that's the starting point, because then you know where you can start from, and slowly, again, kind of slow, gradual exposure of the body to this movement so they can tolerate more and more over time. There are also many cognitive therapies for chronic pain that we use in multimodal pain management. The most evidence-based are cognitive behavioral therapy for pain and acceptance and commitment therapy, which are provided by mental health professionals. I am going to focus briefly on something called pain reprocessing therapy for 2 reasons, partly because it is particularly relevant to nociplastic pain, which I've been focusing on, and then also because it can be delivered by any type of health professional. So physicians, mental health professionals, physical therapists, a lot of people from a lot of different backgrounds can be trained in pain reprocessing therapy. The main idea is that by eliminating the threat associated with pain for patients, you can actually eliminate the pain. And so a big part of that is pain neuroscience education. And that's to help patients reconceptualize their pain as being generated by the brain, often as a false alarm, and to help patients change their own explanatory model for their pain. You want to help the patient gather evidence that's specific to them, that helps them kind of understand this model of pain. And then you coach them through something called somatic tracking. And this is when patients actually pay attention to their pain, not try to be distracted from it, but pay attention to their pain, and even sometimes get into a position that is known to trigger their pain, all while being guided through a lens of safety, being reminded that this is not dangerous to you, there's no injury, with the goal of decoupling the threat and the pain experience from one another. It also includes addressing other emotional threats like anxiety and helping patients gravitate towards positive feelings, which then can, again, help reinforce that decoupling of the threat and the pain sensation. This is a relatively newer cognitive therapy for pain. This is kind of the initial, most referenced study regarding pain reprocessing therapy called PRT. And this study looked at 150 patients with chronic low back pain in Boulder, also known as the Boulder Back Pain Study. And they divided patients into 3 groups. It was randomized, although not blinded. And they provided PRT over 4 weeks, 2 times per week, to a subset of patients. they had a placebo group. The placebo that they provided was they had patients watch a video about the placebo effect and about how effective it was for chronic pain. And then they gave patients, what they told them was, and it was, an injection of saline into the area that was most painful in their back. That was the placebo. So they were very upfront that this was placebo. And then the usual care group was going to do whatever they were going to do anyway. And they measured a variety of things, but their pain intensity decreased significantly for the PRT group relative to the other two groups. And then post-treatment, there was a 66% of the PRT group reported being pain-free or nearly pain-free. And that's in comparison to 20% of the placebo group and 10% of the usual care group. And you can see that at least some of that effect lasted out through 1 year of follow-up. Now, this study had many limitations. It was a single institution, and two of the founders of PRT were providing the PRT therapy. So it's like the best version of it. And obviously there's some potential bias. It was also otherwise fairly healthy white men with low back pain, fairly affluent that participated in this. So again, many limitations to the study, but so be it. This is just a kind of overview of a meta-analysis that was done as a Cochrane database review that looked at all different types of multimodal pain management through a huge range of studies. And they compared pain management, multimodal pain management they compared to usual care, physical therapy, surgery, and then just being on a wait list. What I'm highlighting here is usual care compared to multimodal pain management. And specifically, they saw a moderate effect in improvement of both pain intensity and then disability. They actually didn't see much of improvement in return to work status. So I don't know what that says, but people had decreased functional disability and pain compared to usual care. There were also very few studies that compared multimodal pain management to surgery. In those studies, surgery was more effective at reducing pain, which hopefully suggests that we're selecting the right patients to undergo surgery. But also, not surprisingly, there were many more adverse outcomes from surgery than there were from multimodal pain management, suggesting multimodal pain management is a safe thing. We are still collecting data from our own integrated pain teams here at the VA. We do send standardized surveys to our patients on intake, follow-up, and discharge. But this data comes from a very similar clinic at the VA in San Francisco. And after participation in their multimodal pain management clinic, you can see that their pain interference from the brief pain inventory had a significant decline. So that was sort of how much the pain interfered with someone's a variety of different functions that they do was statistically significant, the decline. Even though their decrease in pain severity was actually not statistically significant. So even though the pain itself didn't necessarily decrease to a significant degree, it interfered less with their daily activities. And then they also demonstrated a significant decline in pain catastrophizing scores for patients who participated. And I mentioned the IPRPs, those integrated pain teams. This was the first and largest study of the VA IPRPs that was published in 2021. And it looked at 6 of the IPRPs across the country and showed a variety of outcomes before and after participation. And they were able to show a 22%, this is an average across the different programs, a 22% decline in pain outcomes questionnaire, a 31% decline in pain catastrophizing, and a 16% decline in the insomnia severity index. And I really want to highlight that decline in the catastrophizing scale, because I mentioned earlier that patients who have high degrees of catastrophizing experience pain more intensely and also are refractory to a lot of traditional pain treatments. So that's a really meaningful decrease. If you can help a patient not to catastrophize around their pain, you can potentially have a dramatic impact on their quality of life. So this brings me to my third point, which is really a call to action to all the internists out here in the audience, because I think we're really particularly well suited to provide pain neuroscience education to our patients. So pain neuroscience education is to decrease that threat associated with pain by helping our patients understand human physiology in a meaningful way, to change patients' explanatory model of their pain, and also to do that in a really respectful way that acknowledges the stigma and suffering associated with chronic pain. I can't tell you how many people just sit and cry in our office during our interdisciplinary intake. So myself, a pain pharmacist and a pain psychologist. And patients will say, no one wants to hear me talk about my pain. So their families are tired of their pain. Their doctors are tired of hearing of their pain, often because they feel they don't have a lot to offer or help. And that's exacerbated if the patient's on opioids, right? Because everyone's on eggshells. Like, are they going to ask me for more opioids? Are they going to take away my opioids? So I often think that we do a lot of just therapeutic interviewing of patients, and they really get a lot out of just having an opportunity to talk about what's going on. And I know this seems like a challenging task, but the stereotype of our subspecialty is that we like talking about complicated things. And anyone who's ever attended inpatient medicine rounds in the morning know that we like to talk. We like to talk about complicated things. And often we're really good at explaining complicated things to patients. And so I have faith that all of you can do this. This is a great resource that can helps give you some tools around how to speak to patients about chronic pain. It's from the Northwest Pain Guidance Group, and there's a clinician toolkit that has some tools for physicians to improve your education on chronic pain. This is a study that was done kind of showing how much impact what we say has on our patients and their explanatory model of chronic pain. So these were semi-structured interviews in New Zealand with patients who had low back pain. And they found that every patient with chronic low back pain actually had something that their clinician had told them that directly impacted their subsequent behavior around their back pain. And so they divided those into three categories of things that the clinician had said. One is sort of providing an explanatory model for the pain. So things like, oh, you slipped a disc, or your back is out of alignment, or things like that. The second are messages of needing protection for the back, so improving posture, improving core abdominal muscles. And then the third category was messages of staying active and reassurance. And then you can see kind of what it led to as far as the patient's interpretation and their subsequent behavior. I have some quotes from the study here that patients kind of reported. They were kind of fearful of becoming paralyzed based on what their doctor said to them, which is really unlikely to occur for most patients with chronic back pain. This patient felt like they had such a weak abdomen and such weak abdominal muscles that they actually terminated a pregnancy because they didn't think that they could handle it, because they perceived themselves as being so weak, which is obviously extreme. But I'm sure that the providers who kind of gave that message had no idea how much of an impact it would have on the patient. And then another patient who indicated that she should have never been a nurse, she was told, because of the anatomy of her spine. And that's in contrast to patients who received kind of reinforcing and reassurance messages, who return to activity more quickly and weren't catastrophizing around their pain. So when I started doing pain management, I feel like I was very much a find it, fix it. Like, let's look at the MRI, let's figure out what's causing the pain, let's fix it. And I encourage you not to do that. There is really, for most patients with chronic pain, due to the complexity we've described, not a singular fix to their chronic pain, which is why multimodal pain treatment can be so effective. But obviously, as a single provider, you can't necessarily provide multimodal pain, but you can provide pain neuroscience education. And you can validate the pain experience, really explain that idea of the pain system as being a threat detection system rather than a damage detection system, and the fact that sometimes the brain misinterprets or has limited information and creates a pain response when there doesn't need to be one. Focus on functional goals, find that functional baseline, promote self-efficacy, and then reinforce that the pain experience can change for patients based on lifestyle and cognitive changes. That is not set in stone. Most of this we do through motivational interviewing. I'm going to go through 4 analogies that I use with patients that can be helpful to convey these messages. The first one is this idea of the overprotective nervous system. And so I often use the example of an oversensitive car alarm. And I say that, if you're walking past a car and you hit the side mirror and the alarm goes off, you weren't trying to break into the car, but the car alarm goes off because it thinks you were trying to break into the car. Kind of think about the brain sometimes and the nervous system having that same response. It's overreacting to something. The second thing I try to get patients to understand is, even if they have something on an x-ray that they are very fixated on that is the cause of their pain, regardless, I try to explain to them that all pain comes from the brain. And I often say, even if I hit you right now with a hammer, it would still be your brain that is telling you that you're having pain. So trying to help them understand that the brain, the sense of pain is coming from the brain, not from an injury. The idea that I mentioned earlier, that pain sensitizes people to more pain. I often use the example of wearing a path in the grass. So saying if you walk in the same path all the time, you're going to wear a path. The same thing kind of happens in the brain. If you're constantly exposed to pain, then that may make you more sensitive to pain. And we can really work on down regulating that. And that's really the fourth thing to try to help patients understand is that pain signals can be turned up or turned down by the brain. You may have heard of the stress bucket, which is sort of things that increase stress and then things that help alleviate stress. The same idea is used in our pain education classes and the AMP program with our integrated pain team, that there are things that kind of increase the pain bucket, negative, unhealthy coping strategies that may also increase the pain bucket, and then those healthy treatment strategies that can help decrease the intensity of the pain experience. I want to give credit to two phenomenal pain psychologists that I work with, Drs. Matt Herbert and Joel Fishbein, because some of this language comes from them. But after doing this explanation, just like I do in motivational interviewing, asking patients, are you open to the idea that the brain is causing you pain? Just like if someone really is pre-contemplative for quitting smoking, you're not going to spend a ton of time trying to work on it. Same thing, if someone really has a hard time understanding this, we're just planting seeds and then hoping that over time we're able to help with behavior change. Again, on a scale of 0 to 10, how much do you agree with this idea? I've also heard them use these phrases, which are incredibly helpful. What would your life look like if you didn't have this pain? And it's fascinating to hear what people say. We've had patients say, I would miss my pain. My pain is all I know. You know, a lot of people structure their entire lives around their chronic pain. And so helping patients sort of understand the very complex relationship they have with their pain can also be therapeutic and make them more open to potentially incorporating other strategies. Really focusing on getting a baseline of activities they would like to do, since we know that sometimes the actual pain number may decline over time, may not decline over time. If patients are achieving those goals, like, oh, hey, you said you wanted to go to the movies. You went to the movies. I know your pain is still a 9, but you went to the movies. You know, that's success. That shows functional improvement. And then really determining if patients are willing to take action to move toward those goals. This is just my pet peeve slide because there's certain words that I want to advise people not to use. The first is chronic pain patient. And just like in other areas of medicine, we really want to use person first language. Chronic pain is not a permanent state. And so a person experiencing chronic pain is a better term to use and more accurate term to use. Instead of there's nothing wrong with you, but that you cannot measure pain with tests. You can't measure a blood test or an MRI that's going to measure pain. No medical fixes doesn't mean that there's no potential to improve. I learned this from a physical therapist. So instead of using degenerative joint disease, the word degenerative really freaks people out, it turns. And so I've completely changed using age-related changes of joints, and don't know that there's evidence to suggest it's better, but this is again pet peeve. This is my pet peeve slide. And then again, not telling people that their pain isn't real or that they shouldn't have this much pain, but the fact is that there's lots of different things that turn up and turn down the volume of pain in your body. I want to give you 2 resources. You may not have time to do everything I just talked about in your clinic, but the Curable is a commercial app that uses a lot of these concepts in educating patients about pain. But the VA has an amazing free app, so anyone, including non-veterans, can access all of the VA's apps in the app stores. And this one's the VA Pain Coach. It includes a lot of what I talked about and is a phenomenal resource. You can download it yourself and check it out, and then refer patients to use it as well. So again, just to reiterate the 3 points that I wanted to make about a lot of chronic pain being nociplastic, multimodal pain therapy being I'm going to say it, the best treatment for chronic pain, and then the fact that you as internists really have an important role to play in effectively treating chronic pain by providing pain neuroscience education. And just this tale of 2 x-rays to circle back to it. So this x-ray on the left, full disclosure, it's not my x-ray because I couldn't access it, but it is essentially what my x-ray looks like because I had a tibial resection as a kid and have very severe osteoarthritis of the knee, and I don't have chronic pain. And I tell you that not to toot my own horn, but rather to just show and part of the reason why I'm fascinated by this process, because it just demonstrates that pain is not nociception and that people can have really high functioning outcomes despite having x-rays that look bone on bone. That's another thing I would eliminate, bone on bone. Don't use that either. Everyone use it, don't use it. Eliminate it. And I think it's also why this work has been particularly meaningful to me. And then lots of thank yous because I have tons of pain colleagues at the VA that are fantastic. And I also want to thank my colleagues at the Vision and then UCSD who have really taught me a lot more about chronic pain. And then particularly the VA leadership who have supported a primary care doctor in being able to work in a multidisciplinary team to provide care for pain. Thank you.
What else do the next day here? Like there's just some
So
teaching purposes.
I know I like really wanted to ask someone to pull it off UCSD. I felt really guilty because all the trainings we do about not logging into other people's charts. I couldn't in good conscience ask someone to log into my chart and steal the image off. Yeah. I think there were some questions in the chat.
I have a question.
Yeah.
Kind of separate because I mean I think this is all super important, but I was also just thinking about how there's so much literature right now about helping people's brains rewire in conditions like depression, anxiety, PTSD, chronic pain maybe. I'm thinking about like ketamine or psilocybin and
Yes.
that's part of the multimodal approach to pain healing.
So yes and yes. And so particularly you mentioned you've mentioned rewiring of the brain. I'll kind of address that in two ways. One is that's some of the cognitive therapies are meant to also do that, is kind of create new associations in the brain. And in fact, pain reprocessing therapy, sometimes people talk about almost similar to PTSD, like a prolonged exposure therapy, where you're trying to have people kind of expose themselves, but in a safe environment. But then, yes, it's outside the scope of this talk for right now, but absolutely, anecdotally, we have had patients that we see in clinic who have gone to, often Mexico to do ayahuasca or ibogaine experiences. And some patients have had remarkable results. Again, that's anecdotal. There is emerging literature around it. And in fact, the VA has some studies going on. We don't provide ketamine for pain at the VA currently. Ketamine is provided in our neurostimulation clinic for depression, but not for pain. We do use TMS, if you've heard of transcranial magnetic stimulation, which provides magnetic currents into the brain that is used for refractory depression, but we also do use that for chronic pain at the VA through our anesthesia clinic. So yeah.
There are a few questions. So thanks for this important talk. Do you have any questions or suggestions as to how to balance the message when a patient's pain sometimes does or did need something is wrong, like a patient with chronic recurrent chest pain that 10 years ago as was actually an acute MI?
Yeah, so that's a great point. So I just to paraphrase the question, it sounds like it's how you balance that with not like ignoring someone's pain essentially. And I would say that by no means is the message I'm sending, and not to assume that pain is nociplastic. Because when you think about that, and nociplastic pain is real pain. Also, there is something that's causing it. It's just coming from the brain rather from tissue injury. And so, yeah, it is a diagnosis of exclusion in many ways because you have to rule out there being a nociceptive or neuropathic cause of that pain. And no pain should ever be ignored or just purely attributed to nociplastic pain until you've done an evaluation that makes you more confident of this. And for example, like that chronic recurrent chest pain really wouldn't meet the criteria for nociplastic pain. In many ways, it's not in multiple regions, right? And so that it may have nociplastic elements for some people, but you'd still not endorse not working it up.
Yeah, so does your clinic refer to ketamine assisted psychotherapy in order to enhance the neuroplasticity and reduce chronic pain?
Great question. Lots of patients ask us about it. Currently, our VA is not providing that due to what they feel is a lack of evidence currently to support its use. But it is, like I said, it is being used in mental health disorders.
Could you please speak a little more about the EMDR?
Yeah, so I forget what it stands for, I have to go back, but it's It's basically the idea of using bilateral stimuli to the body, which can be done with eye movement, where you're moving the eyes. And then it also can be done, I've read, with other types of bilateral stimulation, like audio stimulation and even tactile. And I will not pretend to know how it works, but there is evidence to show that it can. I think the idea, the way I think about it, is that it is turning down the amplification in the brain and the threat signal. I will not pretend to know why.
What do you think about the use of medical marijuana for the treatment program for chronic?
Yeah, so there are some studies, again, outside the scope of this talk today. You could do a whole talk on medical marijuana for pain. I would not be the person to give that. We, as a VA facility, don't recommend or provide marijuana because it's not permitted through the VA. And so it's not something that we talk about or recommend in our clinic. There are certainly, and I think Michelle Sexton, who has spoken in other formats, is a fantastic resource through UCSD, who can provide more specific information for specific patients.
So where do you recommend interest to go for more information or training on this topic?
That's a fantastic question. So the UC Davis Train the Trainer primary care fellowship that I did, and I think that I had support from that program, offered it to us for free, and then also support from UCSD Media to use some time to kind of Dr. Hill also completed that mini fellowship, is a great resource. It is really focused on primary care doctors, but for as far as the nociplastic pain element and pain communication, I definitely recommend the resource that I provided there, the Northwest Pain Information Group, because they have a ton of resources there. The pain reprocessing therapy information is also fantastic on their website. And so I've done the pain reprocessing therapy credentialing, and it's educational in and of itself. And clinicians of any type can really provide it, and you can do it in a variety of different ways. Dr. Portera at UCSD also is trained in PRT and has a clinic where she provides PRT for UCSD patients, and so she's another great resource.
There are more questions coming in, but are we?
I think there's them offline also, so the times.
Yes. Okay, so again, thank you so much for this very interesting talk, Dr. Charat, and thank you all for participating here.
Thank you for having me.
Yes, more questions. Oh, yeah, everyone has some. Oh, sure. Regrets, that's all of it. Sorry for people that percent.
It's